Hi, I'm Wendeline Van Buren from the Mayo Clinic in Rochester, Minnesota, and today I'm going to speak to you about endometriosis, the diagnosis, staging, and reporting. I have no relevant disclosures. With regards to our objectives, we're going to discuss the spectrum of endometriosis pathology. I'll demonstrate the most common and uncommon areas of pelvic and extra-pelvic disease, determine the role of imaging and staging, and discuss the importance of structured reporting. So what is endometriosis? Well, it's a chronic, benign, estrogen-dependent inflammatory gynecologic disorder. It's defined by endometrial glands and stroma outside the uterus and is a common contributor to chronic pelvic pain, dyspareunia, and infertility. It affects approximately 10% of reproductive age women, but can also be seen in the postmenopausal population who are on hormone supplements or who have pre-existing endometriomas which make their own endogenous hormones. Here's a schematic diagram in a coronal oblique view that demonstrates the peritoneal reflection surfaces that endometriosis is seen to commonly involve, including the uterosacral ligaments, which are bilateral structures which insert onto the lower uterine segment. Extraperitoneal locations include the thorax or pleura, abdominal pelvic wall scars seen particularly in the setting of post-C-section, inguinal hernias, and perihepatic and diaphragmatic disease. The interesting thing about endometriomas and endometriosis in general is the histologic classification. So it's a very broad spectrum of disease. We can see superficial endometriosis deposits less than 5 millimeters of peritoneal invasion histologically, most commonly at laparoscopy. Ovarian endometriomas are the classic cystic chocolate cyst lesions that we see on ultrasound and MR imaging very well, and deep infiltrative endometriosis is defined as tissue invasion greater than 5 millimeters from the peritoneal surface. Now, this is a very interesting component to endometriosis as it can be both T1 and T2 hypointense at MRI imaging with T1 hyperintense foci. So with regards to the superficial deposits of endometriosis, these are well recognized at laparoscopy and described as black, white, or red, depending on the degree of fibrosis, scarring, and hemorrhage. They are not routinely seen at MRI unless hemorrhagic. Deep infiltrative endometriosis, on the other hand, can have a vast spectrum of presentations with regards to its shape and its configuration. However, it evolves from a process of hemorrhage, inflammation, and fibrosis in a repetitive cyclic fashion, commonly involving the ovaries, cul-de-sac, broad ligaments, and uterosacral ligaments. With regards to staging, the American Society of Reproductive Medicine and Endometriosis classification system provides us with 4 stages that are attributed to laparoscopic findings, ranging from minimal to severe. The point-based system criteria involves the presence of endometriosis on the ovary and peritoneum, both superficial and deep deposits. The next point or category for evaluation is the posterior cul-de-sac in determining whether it's partially or completely obliterated. The final component is adhesions of both the ovary and fallopian tube and assessing whether or not there are filmy or dense adhesions. So why image and why obtain an MRI for this? Well, imaging in general can be useful in establishing a diagnosis and aid in preoperative planning, particularly if there's involvement of the ureters, diaphragm, or bowel. MRI can help further characterize ultrasound findings, confirm disease in the setting of a negative ultrasound, and identify extra-pelvic sources of disease, such as around the liver or the small bowel. With regards to the MRI protocol, I recommend a dedicated protocol for endometriosis, which includes T2 weighted imaging with a small field of view in 3 planes, and T1 weighted imaging with fat saturation in at least 2 planes, sagittal being one of them to assess well the anterior and posterior cul-de-sacs. I highly advocate for the use of vaginal gel and glucagon to aid in bowel peristalsis, and consider rectal gel for select cases. So this example here demonstrates the protocol considerations. You can see the images in the center of the screen and towards the left from a dedicated protocol using vaginal gel and glucagon. To the far right-hand side of the screen, you see the same example in this patient here with bowel invasive disease. So this lesion here is large, involving the rectum and the uterosacral ligaments at the torus uterinus with fibrosis and hemorrhagic tracts extending into the cervix. With the extent of motion and artifact on this far right image, it's difficult to appreciate the extent of involvement of the posterior cul-de-sac and the cervix for the purposes of operative planning. And I think anyone taking a look at these images would rather be interpreting and reading the images on the center and left-hand side of the screen. So next, how do we address endometriosis, being that it can be a multifocal disease with multiple sizes of lesions, different histologic classifications? Well, I highly advocate for a report template involving the anterior, middle, and posterior compartments for thorough evaluation of all of these areas. So we'll start with the anterior compartment. Of course, the urinary bladder were all common and used to describing. The prevesical space is seen anteriorly. The vesicouterine pouch is seen posterior to the urinary bladder and involves the peristitial reflection. The vesicovaginal septum is seen deep to this, and if disease is identified in this region, it requires specific mention as it requires a deep dissection, and disease in this area is commonly not identified at laparoscopic surgery. So here's an example of bladder invasive endometriosis. You see this low in the vesicouterine space, this T2 hypointense lesion with T2 hyperintense foci, which have T1 hyperintensity, in keeping with hemorrhagic small glandular elements. And this is a 36-year-old female who presented with cyclic pelvic pain and frequent UTIs. In the bottom right-hand image, you see a cystoscopy image showing that there's a protrusion of this lesion into the urinary bladder. However, there is no mucosal involvement. And with smaller lesions, these can easily be missed at the time of cystoscopy. So the MR planning is very useful. Here's another example of deep infiltrative endometriosis of the urinary bladder. We see the ultrasound image to the left of the screen showing the spiculated hypoechoic lesion. And on the CT urogram image on the right, we see that this lesion is actually contiguous with the C-section scar of the anterior abdominal wall. Also in the anterior compartment is the ureter. We see this 43-year-old female who presented with decreased renal function and severe hydronephrosis and atrophy of her left kidney. In examining to the right-hand side of the screen, the image shows a spiculated T2 hypointense fibrotic lesion obstructing that left ureter. A chronic process for this individual, unfortunately. Looking at a slightly more complex case now. So this is the nature of the disease with endometriosis. It can range from very subtle findings to very marked severe findings, and the symptoms may or may not correlate. However, we see here in this case that there is a large T2 hypointense mass with marked thickening of the right round ligament, as well as this soft tissue involvement here of the right ovary. And we can see on the coronal images here on the right-hand side of the screen that this has a somewhat mushroom cap configuration. So in the bowel, we see this commonly because the disease process starts on the serosal surface, and with the subsequent progression of the fibrosis, it creates this smoothly marginated lesion. So we can see the post-contrast imaging in the bottom right-hand side of the screen shows confluent delayed enhancement in both the mushroom cap type lesion, which involves the ovary, as well as the fibrotic tissue extending onto the right uterosacral ligament. Now, I'll just call to your attention, of course, the obstruction of the right ureter, which we see corresponding to the yellow arrows on these images. Next, moving on to the middle compartment. So this is the area that we all have a tendency to look at immediately, involving the uterus, the uterine ligaments, the vagina, the fallopian tubes, and of course, the ovaries. So first thing we're going to look at is the uterus. So adenomyosis is highly associated with endometriosis, and we can see in this individual here on the sagittal T2 weighted imaging, this ill-defined area of hypointensity with lobulations and internal areas of T2 hyperintense cystic change, and it can be very difficult to identify the endometrium in this presentation. I sometimes will use the diffusion weighted imaging to identify what can sometimes be a thin endometrium in the setting of diffuse adenomyosis. Also worthwhile for assessment on the uterine portion of the exam is taking a look for small serosal deposits, which can commonly be seen in endometriosis. So we see delineated by the green arrows here, T1 hyperintense foci in both the anterior and posterior cul-de-sac in this patient with superficial disease. Also, Mullerian duct anomalies can be seen in patients with endometriosis, And often these patients do present at a younger age due to obstruction. Fallopian tube involvement is very common, and approximately 30% of patients with endometriosis can present with hematosalpinx. And we see this 45-year-old individual with complex adnexal mass, dyspareunia, and pelvic pain, showing these findings here at MRI and as well laparoscopy. Next, moving on to the ovary. Of course, the endometrioma is the hallmark of this disease, and the ovaries are most commonly affected. They are the result of cyclic hemorrhage into deep ovarian implants. They're often bilateral and multifocal. So the classic ultrasound appearance is the diffuse low-level echoes. They can be uni or multilocular, and punctate peripheral echogenic wall foci have been seen in approximately 35% of cases. Now, endometriomas should never have internal blood flow, and they should be stable over time. Of course, if you see solid tissue components that have internal blood flow, you always want to be concerned that there may be a process of malignant degeneration occurring. So these are also cases of endometriomas. So just to show you that they don't necessarily have to be diffuse low-level echoes, they can have variable appearances, but again, no internal blood flow. At MRI, what are some of the characteristics that can help us differentiate endometriomas from hemorrhagic cysts? Well, the T2 shading can be seen, as you've seen in the case in the far left-hand side of the screen. And the T2 dark spot, described by Dr. Corwin, increases that specificity even higher, above 90%. So when you see those T1 hyperintense lesions with the shading and the T2 dark spot, you can be fairly confident. Additionally, of course, we can often see a T2 hypointense rim around the endometrioma. And of course, the configuration in the pelvis is often different given the stage of disease, if there are adhesions and fibrosis and retraction of the ovaries, commonly referred to as kissing ovaries. So when the ovaries abut each other in that posterior uterine surface posteriorly, they often have this configuration, further increasing your confidence regarding the disease process. Next, we're going to move on to the posterior compartment, which is a very interesting area because the disease process here can be quite complex. So starting with the perineal body and leading to the torus uterinus, we have the rectovaginal septum and the rectovaginal pouch. So the bilateral uterosacral ligaments are often involved by disease. You can see cases as subtle as the sagittal T1 and T2 weighted images here show where there is subtle thickening, relatively smooth but thicker than usual, and abnormal signal intensity with the T1 hyperintensity that you see to the left of the screen. However, it does not necessarily have to be T1 hyperintense, as we know that the disease process can often be fibrotic and hypointense. The contralateral uterosacral ligament shows us here what is a more nodular focus of T1 hyperintensity with corresponding areas of cystic change here focally along the uterosacral ligament on the right side here. So this is an example of uterosacral ligament nodules. So this is an ultrasound here, and we can see a very tiny implant to the left side of the screen and a larger, more significant nodule that did accompany movement with the uterus on dynamic maneuvers. So you can see that larger lesion, and again, no blood flow was seen within either of these lesions. Also, the area where both uterosacral ligaments insert onto the posterior lower uterine segment is referred to as the torus uterinus. And this is often an area of focal thickening with disease. And we see here in this case exactly that, the T2 hypointense fibrotic thickening with a slightly spiculated appearance with retraction or tethering of the rectum. And this is a really common appearance, and you want to very closely interrogate the rectal serosa to see if there's any deeper involvement, which can sometimes be challenging with small lesions. And as they become larger, our degree of confidence increases. So let's talk about the pathogenesis of intestinal involvement. So we start with the bowel lumen, and the endometrial implant occurs on the serosal surface. Eventually, you see with that cyclic pattern of hemorrhage, inflammation, and fibrosis, this enlarging mushroom cap type lesion with intense T2 hyperintense mucosa, which is preserved. So this does not invade the mucosa. This is a benign process. And we see here on our sagittal T2 weighted imaging, a mushroom cap type lesion, exactly here with thickening of the uterosacral ligaments, fibrosis, slight posterior retraction of the uterus, and invasion of the rectum. And again, here's some corresponding ultrasound images showing the hypoechoic avascular lesions extending from those posterior uterosacral ligaments into the muscularis propria. Moving slightly more inferiorly is the rectovaginal septum, and we see here in this patient a left-sided spiculated T2 hypointense fibrotic lesion with retraction and involvement of the vaginal wall, which we see here well in the sagittal T2 weighted imaging. So this will require partial upper vaginectomy, and this extends as well into the pelvic sidewall region, which we see well on the post-contrast imaging, as well as into the rectal wall. So this is a complex lesion that requires very accurate description for surgical planning. Again, this is below the posterior cul-de-sac peritoneal lining, so the MR and the dictation has to be explicit, otherwise this could be missed laparoscopically. Next, moving on to extra-pelvic endometriosis. While not that common, perihepatic implants can be seen, and we see on T1 weighted imaging and MRI, occasionally T1 hyperintense foci. On T2 weighted imaging, they may be hyperintense as well, relating to some of the glandular elements. It's rare that we see them at CT, but if we do, they can also often be hypodense as well. And diaphragm disease can also be seen and is often plaque-like. Another common extrapelvic location can include the inguinal canals, as we see in this patient here, with the fluid layer and endometrioma in the inguinal canal on the right. Now, you may think that this has the appearance perhaps of an ovary. However, I would draw your attention to the image on the right-hand side of the screen, which shows the ovary more superiorly within the pelvis. The small bowel may also be involved. And so oftentimes bowel disease can be multifocal. So if you see one, do not have that satisfaction of search, go looking for other lesions. So we see here the same C-shaped retractile fibrosis in the small bowel, and on the MR enterography, we see really nicely the hypointense fibrosis in a multifocal distribution. The C-section scar can be involved in the anterior abdominal wall by endometriosis, so very classically patients will present with cyclic abdominal pain very focally in the abdominal wall, and these can be T2 hypointense, but they show very avid enhancement typically early on with delayed enhancement as well. You may see glandular T1 and T2 hyperintense foci within these lesions as well. And typically, these have been treated in the past with surgical resection. However, it's a large anterior abdominal wall surgery. And so recently, we've attempted some ablation procedures, cryoablation. And this is an example you see on the far right-hand image of an ablated anterior abdominal wall endometrioma. The patients report very soon after the procedure complete symptom resolution and have had great response so far. Next, moving on to a few pearls and pitfalls that I think hopefully you will learn from as we did. So the first case is a 50-year-old female post-hysterectomy for evaluation of an adnexal mass. And you see the right ovary with the typical hemorrhagic cysts and lace-like internal echoes, and what is labeled as the left ovary has a solid hypovascular lesion. Now, I would like to call your attention to that appearance of what is labeled as the left ovary, as I think you'll appreciate perhaps going forward that it may actually have a sonographic bowel signature to it. So this patient continued on to MRI, and we see here a mushroom cap type configuration lesion, T2 hypointense with delayed enhancement and preserved T2 hyperintense mucosa. So even though this patient has had hysterectomy, the bowel invasive endometriosis is still present in her pelvis. And I would again advocate looking at all the planes of imaging. On the axial imaging, it can be very easy to potentially overlook this area. So you can see how advantageous the sagittal imaging is here. The next case is a 33-year-old female with cyclic rectal bleeding. You can see her ultrasound images here with normal appearing ovaries and a normal uterus. But I would like to also call your attention to what you see posterior to the uterus, which is actually well seen in the image, although not, of course, the focal point of the image. Hypoechoic lesion here in the bowel that we see to much better advantage when she persists and goes to MRI. We actually see two lesions that are T2 hypointense with hemorrhagic foci centrally and delayed enhancement. And of course, the MRI aids us tremendously for surgical planning because patients who have smaller lesions, so typically less than 3 centimeters, less than 50% of bowel circumference, and unifocal are amenable to a discoid resection. However, if lesions are larger in size, greater in circumference, or multifocal, patients then have to go to a bowel resection, so LAR or APR. So you can see here that this will tremendously impact, this MRI finding here will impact her surgical planning. Next, case number 3 is a 30-year-old with ovarian cystic masses in pregnancy. You can see bilateral lesions. Of course, this is our first tip off here, given our earlier tips, with diffuse low-level echoes involving half of her ovarian cystic lesions and the other half having solid hypervascular tissue. So, of course, we always want to be concerned about malignant degeneration in endometriomas, typically endometrioid or clear cell. But this patient is pregnant, so we should also have a different differential on our list as well. And this patient went to MRI, and we can see very nicely decidulized endometriomas. So the solid component of the endometriomas that we see has sort of an intermediate T2 signal that corresponds to the decidulized placenta. So if you see that very common signal intensity, and of course the T1 hyperintense blood products within the endometriomas, perhaps a posterior retractile or kissing ovaries appearance. And of course, we followed this patient closely to make sure there was no increase in size or other worrisome feature, but these patients can just be followed. There's no resection that needs to be occurring for them, and these lesions do regress, the decidulized elements regress postpartum. Case number 4 is a 54-year-old postmenopausal female with no history of endometriosis. She presented with blood in her stools for 5 weeks and had a normal colonoscopy 2 years previously. So interestingly, at time of colonoscopy, they saw the ulcerated mucosa, and this was a biopsy-proven adenocarcinoma. And the patient was sent for a staging rectal cancer MRI. Now, when we saw the lesion, we noticed that it, of course, went beyond the bowel lumen and extended to the uterus. Under typical rectal cancer staging, this would be a T4 disease situation invading other structures. However, if you look at the configuration of the lesion, it looks very similar to what bowel invasive endometriosis does, with sort of a narrow thickening of the uterosacral ligaments and broad-based mushroom cap extension into the rectum. However, there are a few worrisome features here. Of course, we have mucosal invasion, and lack of the T2 hyperintense rim, which is a little bit difficult to see given the rectal gel. And the enhancement pattern is also atypical. There was very early avid enhancement. Typically, we see more delayed enhancement in these lesions that are just fibrotic. And the restricted diffusion was also a lot more than expected. So we did persist. They did special staining on the biopsy samples. It came back PAX8 and ER positive. The patient was actually sent to excision of both her uterus and the bowel, and she had active and old areas of endometriosis. So this was malignant degeneration of bowel invasive endometriosis. So in summary, endometriosis is a complex disease with a spectrum of histology involving both superficial and deep disease, and it has hemorrhagic and fibrotic implants. It can occur in pelvic and extra-pelvic locations. So this is a vast spectrum of presentations, and imaging plays an important role in predicting staging and surgical planning. I advocate strongly for dedicated protocols and report templates that will result in thorough assessment and communication to referring clinicians. Thank you very much.